Thank you very much for that rather unusual introduction, but thank you very much. Gastrointestinal problems in hypermobile EDS and POTS, etc., I think are confusing to most people, and they are to us as well. And we've been observers in this field for the last 10 years, and I think we learn every day as we go along. And the penny regarding the link between POTS and gastrointestinal symptoms has actually dropped not very, very long ago because of the fact that there is an overlap in a lot of these patients with Ehlers-Danlos syndrome patients. So it's very difficult to know what was purely related to Ehlers-Danlos syndrome and what was actually related to POTS. But slowly, as more patients, as you see more patients, you start to recognize some patterns, and this is exactly what has happened with us. The title of my talk is Gut Complications in Autonomic Dysfunction. So I thought I should have one slide at least which talks about autonomic dysfunction in a more general way before I try and steer towards POTS. So there are a number of different conditions that can cause autonomic dysfunction, and I've got a list there. Diabetes perhaps being the most common, and of course we see this in neurological diseases. There are primary autonomic failure conditions where you cannot really identify a cause, but they produce very devastating symptoms in the gastrointestinal tract and elsewhere. HIV, autoimmune diseases, alcoholism, chemotherapy-induced drugs, and of course autonomic dysfunction has been demonstrated in POTS as well. In some of these conditions, the clinical manifestation is quite profound gastrointestinal dysmotility. It will vary between conditions to conditions, but when you actually have a severe autonomic dysfunction, like severe autonomic neuropathy in patients with diabetes, they will not only have orthostatic intolerance, postural hypotension, etc. They will also have involvement of the gastrointestinal tract, and this can start right from the esophagus to the stomach, small and large bowel. In the stomach, it's particularly devastating because it causes gastroparesis and prevents them from eating very much. And again, the symptoms will mirror that. There will be symptoms that will be prevalent related to the entire gastrointestinal tract, from difficulty with swallowing, reflux symptoms, feeling full after meals, vomiting, nausea, constipation, diarrhea. All of those symptoms may actually occur. But we're here to talk about POTS, and that's what I'm going to actually focus on for the rest of my talk. And I'm going to start by giving you a case history, which I think illustrates quite a lot of features that these patients present with. And Nick actually mentioned the fact that they could be a trigger, they could be an infective trigger, but we found actually in our experience that much broader than just infective triggers can actually produce the symptoms in these patients. But let's to talk about the entire range of prevalence of gastrointestinal symptoms in patients with POTS. And again, as I said in the slide about autonomic dysfunction and gastrointestinal symptoms, these patients often present with a whole range of symptoms of upper, lower GI symptoms, lower GI symptoms of heartburn, nausea, dyspepsia, bloating, diarrhea, constipation, abdominal pain. But are these really specific to POTS? Just to look at how prevalent these symptoms are, and you can see all these three studies demonstrate that almost 50, 60, 70% of the patients will complain of nausea, constipation, abdominal pain, and bloating. But again, it is down to whether this is really related to just the POTS, or is it really the fact that they have a disorder of connective tissue, hypermobile EDS, and even if they didn't have POTS, they would still have the same range of symptoms. And then this study performed in our department by Asma Fikri, she looked at patients coming to secondary care gastroenterology clinics and divided them into non-JHS. At that time, we were still using the JHS term. So non-JHS patients, these without any history of hypermobility, etc. Those patients who were identified as having JHS in our gastroenterology clinic, and those patients who were referred to us through the rheumatologist with the diagnosis of, so those were the tertiary care patients. So the JHS found in our gastroenterology clinic seemed to have milder symptoms. They had quite a range of symptoms as well. But if you actually then looked across the group, including the joint hypermobility syndrome patients referred from rheumatology, then all the upper and lower GI symptoms that I've talked about in the previous slide become really quite prevalent. And what we found is that significantly more gastrointestinal symptoms occur as the severity of JHS increases, or the phenotype becomes more complex with more and more different types of symptoms being present in them. So I think here we cannot say that these symptoms are directly really related to POTS. They may have, POTS may have some bearing on them, but there are other reasons why these patients would have symptoms like changes in gut function related to changes in gut compliance, changes in sensitivity, etc. But let's look at it the other way around. What POTS symptoms can occur after eating? So this is in patients with POTS. Can their symptoms be triggered with eating? And indeed they can. So we have patients who tell us we eat, we get lightheaded, dizzy, we get palpitations, sweating, flushing, drowsiness, we feel pre-syncopal, and some of them will have fainting episodes, especially if they eat and stand up, they will faint. And this is more extreme. Most people don't do that, but certainly there is a small group that will actually do exactly that. So this becomes more relevant when we're actually looking at a patient with POT, because here you're talking about a trigger which may be related to the gastrointestinal tract, and controlling that trigger may help to improve symptoms. So what could be causing these symptoms of postprandial symptoms in patients with POTS? And I think there are two hypotheses, the hemodynamic hypothesis and the dumping hypothesis, and I'm going to talk you through both of these in a minute. So let's look at the hemodynamic hypothesis. We all know that, mothers will tell their children, don't run after you eat. Okay, I don't think they know why they're saying that. But the real reason is that the gut has a lot of blood flow and blood supply. And when we eat, there is an increase in blood flow in the gut, in the gastrointestinal tract, to try and help with the digestion process. And as you can see, there are major trunks of blood vessels all around the gastrointestinal tract. And when we eat, there is some distension, dilatation of the blood vessels to accommodate the increase in blood flow. And I think that in a subject in whom there is already compromised peripheral circulation, such as in POTS, that they have peripheral venous pooling, they have low blood pressure, loss of that circulating volume into the into the abdominal cavity will produce further hemodynamic effects and consequences. And that may well be enough just to trigger symptoms in a severe patient of feeling lightheaded, fatigue, drowsiness, nausea, and bloating. Moving on to the dumping hypothesis, it's worthwhile just looking at what the stomach looks like, and I do apologize to some of my medical colleagues showing them a picture of the stomach, but just acts as a bit of revision for you. So we have many different parts within the stomach. The part just that connects with the esophagus here is called the cardia. And then we've got the fundus. The fundus is where the food, when you first eat, comes and sits there. The fundus relaxes to accommodate the food that is actually coming in and holds it there. And slowly then the food trickles down into the body of the stomach. And then when it's been mixed with acid and other juices, etc., and it acts like one of your mixers, and then the smaller particles start to trickle down through the antrum, and this pylorus, which is normally closed, opens up, and you get food going down. We can see that a little bit more clearly. So somebody's eaten the food is moved down from the fundus down into the body of the stomach and into the antrum. The pylorus is closed. The mixing, etc., carries on over here, and then eventually the pylorus will open, and slowly the food will start to trickle down in a very controlled way, because even the fundus is actually sending the food down into the body in a very controlled way. And we get this gastric emptying curve, which is different from solids and liquids, as you would imagine. For solids, you get a lag time when nothing happens. This is when the solids are sitting in the fundus. and then they start to trickle down into the body of the stomach and then down the antrum and so on. And you get most of the solid gastric emptying, or at least half of the meal that you've eaten being emptied within about 2 hours. For liquids, it's much rapid. The emptying starts pretty much straight away, and then can carry on for a bit longer. So you would imagine that somebody who has rapid gastric emptying may be dumping down the food very quickly, usually liquids, but also solids as well. But moving on, let's see what happens when the food arrives actually in the small bowel, in the duodenum. The duodenum is actually a very vascular organ. So it's actually surrounded by blood vessels. And some of these blood vessels, as you can see, the branches here, they're actually going into the mucosa or in the lining, in muscle and mucosal layers of the gastrointestinal tract. So they're in very, very close contact. The blood in these circulatory arteries, blood vessels, capillaries, etc., is in close contact. And this is where I often try and remind my patients as well when I say them, well, go back to your basic chemistry and physics classes to try and really understand what is actually going on in early dumping. And this is the process of osmosis. So what is osmosis? That if you actually have a concentrated sugar solution in one chamber surrounded, divided by a semi-permeable membrane, and you have a dilute sugar solution on the other side, then the water molecules, they will move from the low concentration towards the high concentration to try and neutralize the high concentration. You can see there a lot of water is actually moved to the high concentration sugar particles to try and neutralize the concentration gradient. And this is what would happen in the gastrointestinal tract as well. So if you actually had a large sugar meal, a carbohydrate meal, drank a lot of water, your stomach is prone to most rapid gastric emptying, which I'll show you in a minute that in these patients there is evidence of rapid gastric emptying. You've dumped down a large concentrated carbohydrate load. And then because of this osmosis, you can get a plasma shift from the blood vessels surrounding the duodenum. And that plasma shift will cause a hemodynamic change. So again, there's going to be a further drop in your peripheral circulatory volume, and that will have consequences. So hence we have this patient with POTS, and if you're eating a large carbohydrate meal, a cheese sandwich, and perhaps various other things added on to that, and then you have a Coke with it, with lots of sugar. And as it goes down the stomach, this dumper truck basically is just dumping things down very quickly. And that quick dumping is producing all those things of fluid shift, hemodynamic changes, etc. And that will lead to then, therefore, the symptoms and trigger the symptoms of POTS. You feel weak, dizzy, vertigo, sweating, tachycardia, tummy cramps, and diarrhea as well, because you get hyperosmolar fluid sitting there in your small intestine and arrives there very quickly, and that can produce diarrhea in its own right. And I have patients who actually say they have to rush to the toilet while they're actually eating. It's urgent, they have to rush. And that's usually a combination of this type of dumping and possibly some mast cell activation as well. We can't completely discount that. There are more than just the physical changes that are occurring. There are some neurotransmitters that are being released, and there's some suggestion that bradykinin, serotonin, and enteroglucagon are being released. There is fluid shifts. And these will lead to both early symptoms. Within 30 minutes, 15 to 30 minutes of eating, the early symptoms will start. And then there is the late symptoms called late dumping that will occur in about 90 minutes or so. And that's because at that time, there is a sudden increase in blood sugar into the blood because of the carbohydrate load. And the blood sugar increase causes an increase in insulin secretion, which overshoots the amount required, and it brings your blood sugar crashing down. And you'll get a reactive hypoglycemia. And again, the same sort of symptoms will come on. And it's therefore important to recognize whether it is early and late dumping so that the management of those is somewhat different. And again, just to emphasize the whole range of symptoms that you can actually get, pre-shock and shock has been identified in some patients with some more severe end of the spectrum, consciousness, loss of consciousness, fainting, we want to lie down and sit, shortness of breath, physical exhaustion, sleep and listlessness, blurred vision, palpitations, etc., etc. You can see, and then lower down you start to see the symptoms of nausea, distension, muturism, borborygmy, irritations, vomiting, etc. So pretty devastating, really. You know, if you don't know what's actually happening, you're going to get quite scared of eating, and that's what exactly happens in a lot of our patients. They don't really know what's hitting them. And then slight separation between early dumping and late dumping. You get sweating in both, less perhaps of the abdominal pain and diarrhea, etc. in the late dumping, but more unconsciousness, tremor, instability. And that's a lot of patients will describe, I need a sugar fix. They will drink something or eat a sugary food very quickly, and then that will trigger its own dumping about 90 minutes later. So in terms of investigating this, I think gastric emptying study is important in these patients, and studies have demonstrated rapid gastric emptying about almost 3 times as common in POTS patients as delayed gastric emptying, and it can be a cause of dumping syndrome leading to postprandial symptoms in POTS. So there are a few studies that have been done, and others have shown that there are differences in the gastric myoelectrical activity in POTS patients, particularly those with the postprandial symptoms, that their electrical rhythm in the stomach is actually not normal. We did a study in using MRI. Heather Fitzke, one of my PhD students sitting in the audience, she and Alex Menes did the study at University College Hospital, and using a water challenge. There's no other nutrient there, just using a water challenge to look at gastric emptying in healthy controls versus EDS patients who had dyspepsia. And indeed, what we interestingly found was that these patients had more rapid gastric emptying in comparison to the healthy controls. So again, that would be, some of these patients may be getting those dyspeptic symptoms, indigestion type of symptoms after meal, could be related to this early dumping. How do you work these patients up? I think it's always useful to start by making sure you take a really good history, you do a systems review, detailed drug history, physical examination, etc., to rule out all the different differential diagnoses as well. And there's a whole range of conditions which can produce similar symptoms of autonomic dysfunction that one needs to make sure that has been excluded. And I won't go through each one of them, but suffice to say that one cannot just put them into one category. One does have to go through a whole exclusion process. Simple investigations, depending on how they present, I think doing a full blood count, LFTs, CRP, inflammatory markers, thyroid function tests, albumin in some of these patients could be important to make sure that some of these hemodynamic shifts are not being caused by hypoalbuminemia. A celiac serology, autoimmune screen, etc. But in some cases, with a lot of postprandial symptoms, you may have to do an endoscopy. Cross-sectional imaging may be required, especially if they're complaining of symptoms that may sound a bit obstructive. And then physiology studies of the upper and lower GI tract can be helpful, particularly gastric emptying studies or esophageal physiology studies, etc. In those with early morning nausea and sickness and vomiting, and if there's a lot of headache involved as well, you might want to consider, and the age group is right, so you might want to consider a CT or MR scan of the head, and particularly to look at Chiari malformation in some of these patients. And of course, we're starting to do this more and more, oral glucose, prolonged glucose tolerance test for at least 3 hours to try and pick up both early and late dumping. So I often ask the lab that please take their blood pulse and blood pressure throughout the study as well while you're doing it. And we hope to pick up that whether they have the reactive hypoglycemia. and autonomic function test, tilt table test that Nick has described. In terms of managing these patients, because ingestion of food is a major trigger for gastrointestinal symptoms, we have to consider that, and we have to consider what are they actually eating. But of course, in the literature, there is a lack of strong available evidence to support specific dietary modifications. Our experience does suggest that dietary alterations can improve symptoms, so you need to take a proper dietary history, find out what they're eating, identify their specific triggers, and avoid unnecessary dietary restrictions. But more specifically, in those with early dumping and late dumping, the advice would be to eat small and frequent meals. Don't load your stomach up too much because you're going to get more dumping. Eat slowly, chew food thoroughly. Opt for low glycemic index foods. So try and avoid processed carbs, refined sugars, etc. in your diet. Increase the fat and protein content in your diet to improve your and to balance your energy requirements. And fat does slow the stomach down. So if you actually have a bit of olive oil with every meal, it will actually slow your stomach because of release of CCK from the small bowel. And this is quite important, to separate liquids from solids. Do not drink 30 minutes before and 30 minutes after a meal. And if you're getting dizzy, then lie down for 30 minutes after a meal, and this can reduce some of the symptoms that these patients complain of. And we generally advise them to increase their salt and water intake. And in fact, sometimes they say, make sure you're well hydrated before you actually have a meal. And there's another trick that I often now have started advising patients, that when you're eating, develop this annoying habit of keep moving your legs so that you try and steal back the blood back into your systemic circulation. Gastroparesis can occur in hypermobile EDS patients that will produce a slightly different pattern of symptoms, and dietary advice related to that, again, is about adequate chewing, avoid insoluble fiber, again, small frequent meal. And here you would say reduce fat intake because fat slows the stomach down, and perhaps have a more semi-solid diet. We've often been asked by colleagues and GP colleagues in particular, when do we refer patients to a gastroenterology clinic? Well, you need to refer to a gastroenterology clinic where they're likely to try and understand all of this and not put them down in the category of mad that Nick mentioned before. But certainly significant postprandial symptoms which are worse and worsening of the usual POT symptoms in these patients, and symptoms suggestive of reactive hypoglycemia. And a proportion of these patients can have delayed gastric emptying, and therefore they will have early satiety, and that will cause the nausea and vomiting. It's worth recognizing this difference in pattern. In terms of pharmacological therapy, I think the mainstay is that you've got to treat POTS well. The autonomic and systemic features of POT need to be treated well. And quite often that will have an effect on improving gastrointestinal symptoms as well. So fludrocortisone, midodrine, etc. A lot of our patients with early morning nausea, that early morning nausea improves. And I think that's really because of the hemodynamic shifts that occurs from lying in bed for a long period of time. They get dehydrated, blood pressure is low, they get central nausea. You improve their hydration, salt intake, fludrocortisone, midodrine, etc., and the early morning nausea will improve in these patients. Octreotide is a analog of somatostatin, and it helps to increase the vascular resistance in the gastrointestinal tract in the splanchnic circulation and slows the stomach down. And in some patients with POTS who are given that for improving their POTS, quite often their gastrointestinal symptoms will improve, and it's used in the treatment of early and late dumping syndrome. And of course, psychological support is very important. In those who have more other general gastrointestinal symptoms of gastroparesis, prokinetic stimulants like erythromycin, procalapride, we also use motilium and maxilon in these patients as well. For diarrhea-predominant patients, anti-motility drugs can be helpful, but finding out what the cause of diarrhea is, if it's dumping, manage the dumping, if it's mast cell activation disorder, managing that can be helpful. And constipation, again, just prokinetics and some of the newer drugs that have come out. Although we say pain antispasmodics and like dicyclovirine, hyoscine, etc., they don't really work in a lot of these patients. And therefore, you have to really try and understand what the mechanism of pain is. But tricyclic antidepressants, SNRIs, SSRIs can work, but of course, we'll be trying to avoid the SNRIs now after next presentation, and antihistamines, etc. So to conclude, POTS patients can present with a range of gastrointestinal symptoms. Some of them just overlap with EDS. Some of them are more specific to POTS. We need to rule out other organic gastrointestinal conditions because they do occur. Celiac disease occurs in EDS patients, and inflammatory bowel disease will overlap as well, and so on. So you've got to rule all of those overlapping conditions out. GI physiological testing may be helpful in defining exactly what the phenotype is of this patient and where the problem is in the gastrointestinal tract. There are no really established guidelines for the management of GI symptoms in POTS, and patients are therefore treated symptomatically. This is something that we need to change, and we are actually meeting next week to try and discuss our strategy for some developing expert-based consensus guidelines for the management of patients with EDS and POTS. And management of POTS with conservative measures and drug treatment can improve GI symptoms, especially nausea and postprandial somnolence, etc. Just to thank a number of colleagues who've really done all the hard work. Asma Fikri was one of our PhD students who did quite a lot of the early work. Lisa Jamieson, I'm learning a lot from. She's a colleague with a background in both pharmacy and now nutrition, and she teaches me a lot about the role of nutrition in these patients, and other colleagues like Adam Farmer, Ahmed Al-Basoda, Heather Fitzke, Asma, all part of our team, working very hard with these patients, and not to forget Ron Freed, who's just sitting over there, and of course EDS UK, EDS Society, and of course POTS UK. Thank you very much. And not to forget the patients, of course.